Okay, I want you to just for a second close your eyes. Picture a typical hospital floor. You can probably hear it right now.
Oh, yeah. The beeps.
The beeps, right?
Yeah.
The constant rhythmic beeping of the cardiac monitors, the hiss of an oxygen machine.
The squeak of shoes on that polished linoleum.
Exactly. It's a whole sensory experience,
Mm.
but it all screams one thing.
Control. Everything is measured. Everything is controlled.
100%. If a patient's O2 sat drops, an alarm blares. If you need help, you hit a big blue button on the wall and 6 people sprint into the room.
You're in a fortress.
Yeah.
A fortress of safety, surrounded by data and backup and protocols for everything.
It's where we as nursing students learn to feel safe. It's where we feel competent.
It's the acute care bubble. It's where all the TV shows happen, right? The heroics.
But now I want you to take all of that away. Just strip it out, silence the alarms, turn off the monitors, get rid of that backup team,
Okay.
and then walk out the hospital, sliding glass doors, get in your car, and drive to a neighborhood you have probably never been to before. You walk up to a front door where the paint is peeling, you can hear a dog barking inside, and you knock.
And right there, that's the moment. That's the terror moment for so many students.
It is. It's the moment the safety net just vanishes. And that is exactly where we are starting this deep dive today. We are looking at one of the most, I think, misunderstood, definitely most challenging, and honestly one of the most high-stakes areas of healthcare.
Community and public health nursing.
Exactly.
And it's so fascinating because students, they often dread this rotation. They really do. They think, oh, great, I'm just going to be, handing out pamphlets at a health fair or something.
Right, that it's soft.
Yeah. But the reality is, this is kind of like the special ops of nursing. You are operating without a net, often in these completely uncontrolled environments, trying to solve problems that, frankly, medicine alone cannot touch.
Well, we have a huge stack of source material today. We're looking at 5 really comprehensive chapters that cover everything from the history, the toolkit, the ethics, and the data behind this whole field.
And the mission for us today is pretty simple.
Yeah, we're going to try to bridge that gap. The gap between what we call the acute care mindset, fix the broken bone, and the public health mindset.
Which is fix the broken sidewalk that made the person fall and break the bone in the first place.
Perfect. But to do that, we have to acknowledge that anxiety, that terror moment. Most students come into the specialty so focused on skills.
Oh, absolutely. It's all about, can I start an IV? Can I
Right.
drop a Foley catheter? Can I titrate a drip?
Right. And then you get to community health, and suddenly those skills are, well, they're not really the point anymore.
Not in the same way.
To ground this, let's start with the story of Madison. This is right from the intro of our source text, and I think any listener who's ever been a student is going to feel this one deep in their bones.
Madison is basically the avatar for this anxiety. She's a 24-year-old nursing student. She spent 3 years memorizing sterile fields, lab values, IV drip rates.
She knows the machines. She feels competent inside that box, that hospital.
Totally. And then, bam, she's assigned to a community health rotation.
Right.
And her equipment list, it's almost funny.
It's a stethoscope, a thermometer, a paper tape measure.
And a baby scale in a bag. That's it.
That's it. No crash cart, no pharmacy just down the hall, no code team.
And her assignment is heavy. It's not just observing. She has to do home visits for a 16-year-old mother named Anna and her 4-month-old baby, Jose.
And Madison's internal monologue here is so incredibly relatable. She is panicking.
Oh, full-on panic.
She's thinking, I'm 24, I don't have kids. What on earth can I possibly tell a teenager who is actually living this life day in and day out? She's going to see right through me.
She felt like a total imposter. She felt like she had nothing to offer because she couldn't offer for procedure.
Which is the classic fear, isn't it? That without all the medical stuff, without the pills and the procedures, a nurse has no real value.
But Madison went. She did it anyway. She drove to this disheveled apartment building, walked past a broken security gate, and she knocked on that door.
And it wasn't some movie moment where they immediately connected. Anna was, defensive. She didn't want a nurse coming in to judge her. She was probably expecting a lecture.
Of course. But Madison just kept showing up every Thursday for 15 weeks. And this is the turn in the story that I think is so crucial for students to hear.
They didn't really do medical things, not in the way we usually think about it.
No. They weighed the baby. They talked about baby-proofing the apartment, moving sharp objects, covering the electrical outlets. Simple stuff.
They filled out those developmental questionnaires together. Madison helped Anna figure out the bureaucracy to get immunization appointments scheduled.
It all sounds so mundane, doesn't it? I mean,
Yeah.
compared to running a code blue in the ER, watching a baby get weighed feels slow.
It does, but it's foundational. It's everything. They were building trust. Madison wasn't treating Anna like a statistic, like a teen mom. She was treating her like a capable parent.
She even encouraged Anna to stick with her GED classes. She became a partner in Anna's life, not just a healthcare provider who swooped in and out.
Okay, so now fast forward. This is the payoff. This is the moment the light bulb goes on for everyone. Madison graduates. She lands her dream job in the emergency room.
She's back in the fortress.
Back in the fortress, she's got her blue scrubs, her stethoscope, she's in her element. And one night, who walks through those automatic doors?
It's Anna and baby Jose.
Yep, Jose had burned his hand on the stove.
Now, you have to picture the scene. A teen mom, a crying toddler, a burn injury, the other nurses in that busy ER. They're doing what overworked acute care staff often do.
They're mumbling, they're giving the side eye. You can practically hear the whispers.
Where was the mother? So irresponsible? Maybe we should call CPS.
They were judging the single snapshot they saw in that ER bay. They saw the symptom.
But Madison had the whole movie. She had the context.
She knew that Anna was busting her butt in GED classes to try and lift her family out of poverty. She knew Anna had to leave Jose with a neighbor just to get to class because childcare is ridiculously expensive.
And she knew the neighbor wasn't used to toddlers. And in a split second, a single moment, Jose grabbed a hot pan of refried beans.
And because Madison understood that community context, the struggle for education, the lack of safe and affordable childcare, the reality of poverty, she didn't judge.
Not at all. She treated the burn, she gave Anna clear instructions she knew she could actually follow, and she sent her home with dignity.
And in that moment, Madison realized that her community rotation didn't make her a soft nurse. It made her a sharper, more effective ER nurse.
That's the lens. That's what this is all about.
That is the lens we want to give you today. Because whether you end up in the ICU, the OR, or a school clinic, you need this lens. So to get there, let's get a little technical for a moment. You have to understand the terrain. The sources throw around three terms that sound the same, but they mean very different things.
Community, population, and aggregate.
And for any student listening, prepping for exams, precision really matters here.
It does. Let's start with community. The secret sauce for a community is interaction.
So people are actually talking to each other? There's a connection.
Right. There has to be a sense of belonging. A geographic neighborhood where neighbors know each other and have block parties, that's a community. A church group is a community.
Yeah.
A local chapter of Mothers Against Drunk Driving, MABD, that's a community. They share a bond, they interact, they function collectively on some level.
So that's distinct from a population.
Very. A population is more of a statistical bucket. It's a group of people who share at least one characteristic, but they might never say a word to one another.
Like all people in the United States over the age of 65.
Perfect example.
Yeah.
Your grandmother in Ohio and my grandfather in California are in that group, but they don't know each other. They aren't hanging out.
They don't have a club.
Exactly. But for epidemiology, for tracking disease trends, for allocating resources for research, we need to be able to group them together. That's a population.
And the third term, aggregate.
Aggregate is basically the umbrella term. It's a loose grouping of distinct individuals considered as a whole. It can encompass both communities and populations. It's the broad category you'd use as a nursing student when you're defining the group you're serving.
So if a community is the dinner party, a population is the census data.
That is a perfect way to frame it.
But knowing the terms is just the start. The real shift, the thing that Madison learned, is how you think about the problems. The text calls this upstream thinking.
I love this concept. It's so powerful.
The sources use the story of a little boy named Jackson to illustrate this. And it's basically the why game that every toddler plays, but with life or death stakes. I think we should play this out because it perfectly shows the difference between bedside nursing and public health nursing.
Let's do it. So you have a 4-year-old boy, Jackson. He's in the hospital. He has pneumonia.
Okay, so the acute care view, the hospital view is very linear. It's immediate.
Right. Jackson has an infection. What do? We give him antibiotics. We monitor his oxygen saturation. We give him breathing treatments.
The infection clears up, his breathing gets better, and we discharge him. Job done.
The chart says resolved. We feel good. We fixed him.
But the public health nurse looks at Jackson in that bed and asks the first simple question, why? Why does this 4-year-old have pneumonia?
Well, the immediate answer is that he had a bad cold that got way worse because he has underlying asthma.
Okay, so we go one step upstream. Why is his asthma so poorly managed? Why is his chest so reactive and tight all the time?
Because he lives in an apartment that has a serious infestation of cockroaches and visible black mold on the bathroom walls. Both are massive, well-known asthma triggers.
So now we're out of the hospital and in his house. Next question. Why is he living in a moldy apartment with roaches? Why don't they just move?
Because his family is living below the poverty line. The housing is substandard. The landlord is a slumlord who won't make repairs, but it's the only place they can afford in that zip code.
Okay, we're getting further upstream. Why are they so poor?
Well, maybe his mother works 2 different minimum wage jobs, but she doesn't have the education or the vocational skills to get a job that pays a living wage.
Or maybe she can't find affordable, reliable childcare, which limits the hours she can work or the jobs she can take.
And there it is. The hospital treats the pneumonia. The public health nurse looks at the mold, the housing codes, the minimum wage, the job training programs, and the availability of affordable childcare.
If you treat the pneumonia but send Jackson right back to that moldy apartment, you haven't fixed the problem. You've just hit the snooze button on the alarm.
He'll be back in the ER. It's almost a guarantee. Upstream thinking means trying to fix the conditions that made him sick in the first place. It's about prevention, not just reaction.
It's looking at what the sources called the social determinants of health.
Exactly. Where we live, where we learn, where we work, and where we play affects our health far, far more than what happens inside a doctor's office. Your zip code is often a better predictor of your health than your genetic code.
That's a powerful statement. And this leads to another big mindset shift the text highlights, the health continuum. We tend to think in a binary. You're either sick or you're well. You're in the hospital or you're not.
Which is just so false. It's not a switch, it's a spectrum. The sources give this great contrast to explain it.
Let's hear it.
Okay, so you can have a 75-year-old woman with chronic renal disease. Her kidneys are failing. She's on a strict diet, multiple medications. But she is taking her meds perfectly. She's sticking to her diet. She's engaged with her family. She's mentally sharp.
So within the context of her chronic illness.
Within her context, she is functioning at her optimal potential. She is, in a very meaningful sense, well, she's on the wellness end of her personal spectrum versus a 16-year-old high school quarterback.
Yeah.
Physically, if you look at his lab work, he's perfect. He's an athlete, no chronic diseases. But he is profoundly depressed, he's socially isolated, and he's engaging in risky behaviors like vaping or reckless driving.
On a medical chart, he's the picture of health.
Right. But on the health continuum, he's ill. He's way on the illness end of his spectrum.
And community nursing is all about trying to push everyone, regardless of where they start, a little bit further toward that wellness end.
That's the goal. Not to cure everyone, but to optimize everyone's potential for health.
So if that's the goal, what's the toolkit? You can't just order a CT scan for a neighborhood or write a prescription for poverty.
No, you can't. The source material breaks this down into 3 core functions of public health. And for students listening, these are the pillars. This is the foundation of the entire specialty.
Assessment, policy development, and assurance.
You got to know them.
Let's break them down. First, assessment. This isn't just listening to a patient's lung sounds.
No, this is assessing a whole zip code. It's diagnosing a community. You're a detective. You interview community leaders, the pastors, the school principals, the barbers.
You do something called a windshield survey.
Which is literally driving around and observing. Are there sidewalks? Are there grocery stores with fresh produce? Or is it just liquor stores and fast food joints? Are there parks? Are people outside walking their dogs?
You're collecting data.
And analyzing it. Who lives here? What are the main causes of death and disease? What are the trends? It's detective work on a macro scale.
Okay, so you've done your assessment, you've gathered the intelligence, you know the problems. Then comes the second function, policy development.
This is where nursing meets politics. And it has to. You take that data and you advocate for change.
So in Jackson's story, if the assessment shows sky-high asthma rates in his neighborhood,
policy development isn't about giving every kid an inhaler. That's a temporary fix. It's about using the data to lobby the city council for stricter housing codes to eliminate mold.
or fighting for a new health clinic to be built in that neighborhood, which is a food desert.
Exactly. It's about systematically moving the resources to where the data says they are needed most. It's changing the system, not just patching up the people the system breaks.
And the third one, assurance, sounds a bit like customer service, but it's much more serious than that.
It's about accountability. It's making sure the promises are kept and the services are actually there. It's the follow-through.
So if you pass a law about restaurant sanitation,
Assurance is making sure health inspectors are actually out there enforcing it. If you say you've opened a new clinic, assurance is making sure it's staffed, the hours work for working people, and that the bus line actually runs to his front door.
it's assuring the public that the safety net actually works.
Yes, assessment is finding the problem. Policy development is creating the solution. Assurance is making sure the solution is real and accessible to everyone.
And within these functions, there's a framework that I know for a fact shows up on every single nursing exam, but it's also just a really practical way to view the world.
The 3 levels of prevention: primary, secondary, and tertiary. This is the absolute bread and butter of the field. You have to know this, Gold.
So let's simplify them for the listeners. Primary prevention.
Think before the problem even exists. You are doing something to stop the disease or injury from ever happening in the first place. You're removing the risk factor.
Vaccines are the most obvious one, right?
The classic example: you give the measles vaccine so the child never gets the measles. But it's also teaching a nutrition class to a group of healthy teenagers so they don't develop diabetes 20 years from now.
Or installing grab bars in an elderly person's shower before they fall and break a hip.
Perfect. It's putting fluoride in the water supply. It's advocating for seatbelt laws. If the disease or injury hasn't happened yet and you're trying to prevent it, that's primary.
Got it. Okay, next is secondary prevention.
Think screening. The problem might already be there, but we want to catch it as early as possible to treat it more easily and prevent it from getting worse.
So any kind of screening test.
Exactly. Blood pressure checks at a health fair. Secondary. You aren't preventing high blood pressure by checking it. You are finding it early.
Mammogram.
Secondary. Pap smears. Secondary. Checking kids for head lice at school.
Definitely secondary.
You're not preventing the lice from getting there. You're finding them early to stop a major outbreak. The goal of secondary prevention is always early detection and prompt treatment.
Okay, that makes sense. And finally, tertiary prevention.
The ship has sailed. The disease or injury has already happened. Now we're in damage control mode.
So trying to manage it.
We want to prevent it from getting worse, prevent complications, and maximize the person's quality of life.
So any kind of rehabilitation.
Exactly. Stroke rehab is a classic tertiary intervention. Teaching a patient who already has diabetes how to do proper foot care so they don't get an ulcer and need an amputation.
You can't cure the diabetes, they have it. But you can prevent the amputation.
And that's tertiary. Case management for someone with a complex chronic illness is almost always tertiary prevention. You're coordinating their care to keep them as healthy as possible.
Well, primary, stop it. Secondary, find it. Tertiary, manage it.
It's the simplest way to remember it. And guiding all of this on a national level is the government's massive report card.
Healthy People 2030.
It really is like a national report card for health. Every 10 years, the federal government sets very specific, measurable goals for the nation based on tons of data.
And they track these leading health indicators.
Right. Things like obesity rates, suicide rates, access to health insurance, air quality. It sets the national agenda for where funding and effort should go.
So, how are our grades? How are we doing?
Honestly, we need improvement. The source material notes that in the 2020 review of the previous goals, we only met the targets for about 21% of the objectives.
Wow, that's not great.
It's not. And some things, alarmingly, actually got worse. Suicide rates and the prevalence of major depression both saw a statistically significant increase.
That's just so heavy. It really underlines why this upstream work is so critical. We clearly aren't winning this battle just by building more hospitals or prescribing more pills.
We have to change the conditions.
So I want to pivot now to where this work actually happens. Because the image of the visiting nurse with the little black bag is iconic, but is it still accurate?
It's the origin story, for sure. But the sequel is way bigger and more diverse. Yes, home health is still a huge and vital part of this field. But community nurses are everywhere.
In schools, for one.
And let's be really clear about this. School nursing today is not just putting Band-Aids on scraped knees and calling parents when a kid has a fever.
Not at all.
School nurses are managing complex chronic conditions like type 1 diabetes and severe asthma. They're doing mental health counseling and crisis intervention. They are providing sex education. They are on the front lines of tracking infectious disease outbreaks.
For a huge number of kids, especially in underserved areas, the school nurse is the only health professional they see on a regular basis.
They are the de facto public health officers for that entire little village we call a school.
Then there's occupational health.
Yep. Nurses in factories and corporate headquarters, they're focused on keeping workers safe from chemical exposures, ergonomic injuries, workplace stress. If you work at a major company, the nurse there is doing public health, making sure the workplace itself doesn't make you sick.
I was fascinated by the section on faith communities.
Parish nursing. It's such a unique niche. It's about combining holistic health with spiritual care, all within the trusted context of a church, synagogue, or mosque.
It leverages the trust people already have in their faith leaders to promote health and wellness.
Exactly. And then you have the really tough environments, what the text calls the street.
Outreach to homeless populations.
This is extreme community nursing. You are literally going under bridges, into encampments, building trust with people who have been failed by pretty much every other system in society. It requires incredible grit and empathy.
The sources list 7 key roles that nurses play across all these settings. We don't have to go through all of them, but a few really stood out to me as being so different from the hospital. The role of educator.
The leverage you get as an educator in the community is huge. Think about it. In a hospital, you're doing discharge teaching for one patient who is probably tired, in pain, and on medication.
And they retain about 10% of what you say.
If you're lucky. In the community, you teach a parenting class to 30 new parents at once. You just impacted 30 families, maybe 100 people in a single hour. That is scale. You're empowering people with knowledge to care for themselves.
The role of advocate. This one is powerful.
This is about fighting for people who don't have a voice in the system. The text gives this incredible example of a nurse who organized an entire tenant community.
After an 8-year-old boy was shot in their apartment complex.
Right. She didn't just treat the wound, she organized meetings, helped them find a lawyer, and fought with them to demand the landlord install better lighting and security. That is advocacy. She stepped way out of the medical lane and into the social justice lane because that's what her patients needed. That is nursing.
And all of this work in all these roles happens in what the text calls an uncontrolled environment.
And this goes right back to the Madison story. In the hospital, the nurse has the power. It's the nurse's territory. The patient is in a gown. The nurse is in a uniform.
In someone's home. You are a guest. You have no power.
Zero. If there are loose rugs on the floor that are a trip hazard, you can't just throw them away. If there's a reactive dog, you have to negotiate with it. If the family smokes in the house, you can't ban it. It's their house.
You have to be so creative. You can't just order a low-sodium diet from the kitchen.
You have to open their refrigerator, see that all they have is canned soup and bologna, and figure out a realistic plan based on that reality. You have to be MacGyver every single day.
It demands this level of improvisation that the highly structured ER just doesn't. Now, I really want to shift gears to the history, because we are standing on the shoulders of some serious giants here. And I have to say, the source material completely rewired my brain on Florence Nightingale.
Oh, she gets so typecast, doesn't she? The lady with the lamp. Gentle, quiet, holding hands.
Right. But the reality is she was a data nerd. She was a brilliant, fierce statistician.
A ruthless one. When she went to the Crimean War, she wasn't just there to offer comfort. She looked at the numbers, and she realized the British soldiers weren't dying primarily from Russian bullets.
They were dying from filth.
From filth. From typhus, cholera, dysentery, from bad air, contaminated water, and a total lack of drainage.
And she didn't just say it, she proved it.
She proved it with her famous rose diagram, which was an early and incredibly effective form of a pie chart. She used data visualization to show the generals and politicians that simple sanitation reforms were saving more lives than the surgeons were.
She identified her 5 components of a healthy environment: pure air, pure water, efficient drainage, cleanliness, and light.
Which, if you think about it, is the basis of modern hospital infection control and public health infrastructure. She was an epidemiologist before the word really existed. She used math to save lives.
Incredible. Then you have Lillian Wald. If Nightingale is the grandmother of modern nursing, Wald is the undisputed mother of public health nursing.
No question. It's 1893. She's in New York City. The Lower East Side tenements are overflowing with immigrants living in squalor, rampant with disease and poverty.
And she didn't just commute in to help, she moved in. She and her colleague Mary Brewster founded the Henry Street Settlement.
They lived there. She saw firsthand that you couldn't just treat the tuberculosis. You had to treat the social conditions that caused it, the overcrowded tenement housing, the dangerous child labor practices.
She actually coined the term public health nurse.
She did, and she was a relentless political activist. She fought for women's suffrage, helped found the NAACP. She was an absolute force of nature. She proved fundamentally that nursing is political because health is political.
And then we get the visual that I just can't get out of my head. Mary Breckinridge.
The Frontier Nursing Service, 1925. I mean, just picture this. Nurses on horseback, their saddlebags full of medical supplies, riding up these muddy, treacherous mountains in rural Kentucky, in the snow, in the rain.
They were literally delivering babies in one-room cabins that didn't even have roads leading to them.
And again, it comes back to the data. Breckinridge was meticulous about data collection. She proved that her nurse midwives on horseback drastically reduced maternal and infant mortality rates in these remote, impoverished populations.
They were getting better outcomes than the best hospitals in the big cities at the time?
It proved a revolutionary idea. If you bring skilled care to the people where they are, you save lives. It wasn't about the fancy building, it was about the skilled nurse and the access.
That legacy of going where the need is brings us to the modern challenge. How do we know that what we're doing today actually works? We can't just operate on good vibes and horseback rides anymore.
No, we need cold, hard evidence. Evidence-based practice, or EBP, it is the non-negotiable backbone of modern nursing and public health. We can't just say, this program feels nice and seems like a good idea.
You have to prove it changes outcomes. Funding depends on it. Lives depend on it.
And the sources give a really powerful modern example of this with the Nurse-Family Partnership, or NFP.
This connects right back to our opening story with Madison and Anna.
It does. The NFP is a very specific evidence-based program where registered nurses visit low-income first-time moms from pregnancy until the child is 2 years old.
And the text tells the story of an NFP nurse named Jody. She was visiting a pregnant teen in a high school, and the teen's life was just chaos, abuse from her family, poverty, instability. And Jody felt helpless.
She had that same thought Madison did. I'm just talking to her. I'm not fixing anything. I'm not giving her a pill or doing a procedure.
But the data says otherwise. Overwhelmingly.
We have 40 years of rigorous, randomized controlled trials on the NFP. 40 years of evidence. It proves that these visits result in better pregnancy outcomes, significantly less child abuse and neglect, and better economic self-sufficiency for the mothers years down the line.
So Jody, on that one tough Tuesday afternoon, might not see the result, but the evidence proves that her intervention works. It literally breaks the cycle of poverty for the next generation.
It's playing the long game. And to do that kind of research, to build that evidence, nurses use a specific tool called a PT question.
It's a formula, basically, a way to ask a clear, answerable research question.
Right. It stands for population, intervention, comparison, outcome, and time.
So instead of asking a vague question like, does home visiting work?
Which you can't really measure. You ask something like, in low-income, first-time mothers population, does participation in the Nurse-Family Partnership Program, intervention, compared to standard prenatal care comparison, reduce rates of child maltreatment outcome within the first 2 years of life?
Time. That is a question you can actually answer with data. That is how we build the science of nursing.
Absolutely. But, working in the community isn't just about cold, hard data and research questions. It gets messy. It gets ethical. And the ethics here are profoundly different than in the hospital.
How so?
Well, in the hospital, your primary ethical duty is to one person, your patient in the bed. In public health, your patient is the entire community.
So you're constantly balancing the good of the group, what we call utilitarianism, against the rights of the individual.
And they can be in direct conflict.
The story of the nurse Andrea Vargas in the text just highlights this conflict perfectly. It really stopped me in my tracks.
This is such a tough one, and it's a real-world scenario. Andrea is a nurse visiting a family living in deep, deep poverty. They're in a converted outbuilding, basically a shed. There's no running water.
And the kids have chronic lice and recurrent staph infections from the unsanitary conditions. It's a clear health hazard.
So the acute care instinct, and frankly, the legal instinct in many cases, is report it. You call Child Protective Services. You get the kids out of that dangerous environment.
But Andrea pauses. She knows the bigger picture. She knows the context.
The family is undocumented. If she calls CPS, it could trigger a chain reaction. The family will likely get evicted, they could get separated, they could even get deported. The children might end up in the foster care system, separated from parents who love them, but are just incredibly poor and marginalized.
But if she stays silent, the children remain at risk of serious infection.
Exactly. It is a brutal ethical dilemma. It's a clash of core values. the sanctity of life and the duty to protect children versus the right to self-determination and the importance of keeping a family unit together.
So, what's the right answer?
The text doesn't give you a clean one, because there isn't one. That is the reality of this field. You have to weigh the potential harm of intervening against the definite harm of doing nothing.
You have to consult with ethics committees, with your supervisors. You have to look for a third way.
Right. Is there a way to fix the housing situation without calling the authorities? Can we connect them with a community organization that can help with repairs or rehousing? Can we aggressively treat the infections and provide education on hygiene, even in those conditions? It requires such deep ethical reasoning.
And it brings up that crucial distinction between equity and equality.
Oh, this is so important. Equality is giving everyone the exact same thing. Equity is giving people what they need to get to the same outcome.
So the classic image is three people of different heights trying to watch a baseball game over a fence.
Exactly. Equality is giving each of them one identical box to stand on. The tall person can see great, the medium person can just see, and the short person still can't see at all.
Equity is giving the tall person no box, the medium person one box, and the short person two boxes, so now everyone can see the game.
In health terms, equality is giving everyone the same pamphlet on nutrition printed in English.
Yeah.
Equity is recognizing that one person can't read, another doesn't speak English, and a third lives in a food desert and can't afford fresh vegetables.
So you give them the specific support they need, maybe an audio version of the info, a translator, a cooking class using canned goods, a voucher for a food pantry to help them reach the same health outcome as everyone else. It's about removing the specific barriers each person faces.
And you cannot achieve equity unless you understand culture. You cannot just bulldoze people with your Western medicine way of doing things.
If you are ethnocentric, if you believe your way is the only right way, you will fail in this field. People will just ignore you.
100%. The source material had a fascinating example of this regarding the Hmong community and cervical cancer screening.
Yes, this is a classic case study. Public health officials were getting really frustrated because Hmong women in the community were refusing to get pap smears.
And from a purely biomedical perspective, a pap smear is a standard life-saving screening test. The doctors and nurses were thinking, why won't they comply? Don't they understand the risk? Are they just being ignorant?
But the reason had nothing to do with ignorance. It had everything to do with cultural values.
Yes, the lithotomy position, having to put your legs up in stirrups, was considered deeply, profoundly immodest in their culture. It was a violation of their values. It was shameful.
So what did the public health researchers do? Did they just lecture them harder about the importance of screening?
No, and this is the beautiful part. They adapted the care to the culture. They worked with the community and developed a specific, less invasive urine test that could detect the HPV virus, a precursor to most cervical cancers.
Wow. So it respected the cultural value of modesty while still achieving the vital public health goal of screening.
That is cultural competence in action. It's not about forcing the patient to bend to the system. It's about bending the system to serve the patient and their community.
That is such a perfect example of that phrase you hear all the time, meeting people where they are.
That phrase, meeting people where they are, is the mantra of this entire profession. You meet them geographically, physically, culturally, and emotionally. You don't wait for them to show up sick at the hospital door. You go to them.
So let's bring all of this home. We've covered this huge shift from the acute care mindset to a population health mindset. We've looked at the toolkit assessment, policy assurance, the levels of prevention. We've seen the history from Nightingale's charts to Breckinridge's saddlebags.
And we've waded into the complex ethics of working in the real world.
Community and public health nursing it's the long game of healthcare.
It really is. In the ER, you fix the broken arm, you put on the cast, and they leave. You get that immediate gratification. In the community, you might be trying to change the trajectory of an entire life or a whole family.
You're trying to fix the mold in Jackson's apartment so he never needs the ER for his asthma again. You're building a relationship with a teen mom like Anna so her child grows up safe and ready for school.
It's quieter work. You don't get the same adrenaline rush. But the impact is often so much deeper and more lasting.
It takes a different kind of courage, I think.
It absolutely does. And it goes back to that Gallup poll that's mentioned in the source material. For 18 years in a row, nurses have been rated the most honest and ethical profession in America.
Beating out doctors, clergy, judges. Everyone.
That public trust is your currency in the community. It's everything.
It is. When you walk into a community, when you knock on that door and walk into someone's home, you carry that weight. You are a guest, but you are also a lifeline. You represent a system that can either help them or hurt them, and it's up to you to be the helper.
Well said.
So, here's the final thought we want to leave you with, especially if you're a student listening to this. Are you ready to trade the safety of that blue button on the hospital wall?
Are you ready to trade the controlled, sterile environment of the ICU for the complex, messy, uncontrolled, but incredibly rewarding reality of the community? Because at the end of the day, the community is where health actually begins.
A powerful place to end. Thanks for diving deep with us today.
Take care, everyone.